Patients with wet age-related or dry or wet age-related macular degeneration also suffer from a wide variety of systemic comorbidities as well, oftentimes. What did your study find about the impact of intensive statin treatment on the progression from dry to wet age-related macular degeneration?
Yeah, that's an important question. And also to clarify, it's not only they also suffer from these systemic risk factors. It's actually previous studies have shown there are like similarities in the risk factors and pathogenesis between AMD and atherosclerosis or cardiovascular disease. And that's why it was thought that statins, which are the mainstay treatment for hyperlipidemia and atherosclerosis, will be beneficial in AMD. And that's why we basically and the literature was actually controversial up to like a few years ago when like a nice two studies, although both of them were small studies from our group and other groups, showing that the dose of statin and the type of statin is important, as well as selection of patients with AMD. So it should be a specific, like what we call hydrophobic statins, like atorvastatin, and the dose should be like probably very high, such as 80 milligram daily, which is not very typical for patients to use basically with atherosclerosis. We found that we know that there are like two types of AMD, the dry form, which like characterized by drusen, which are subretinal exudates, and the wet form where there is like new blood vessels growing under the retina and causing severe vision loss. So we found that, and we don't have many choices basically to prevent the progression from dry to wet form. We found that statins, or previous studies at least, found that a very high dose of atorvastatin, like 80 milligram daily, will prevent this progression from dry to wet AMD. So we wanted to further investigate this question and see if it's still also like that we get the same conclusion in our population of patients. And if not, what are the characteristics, the clinical characteristics that differentiate patients who convert to wet AMD versus those who don't convert to wet AMD on this dose? And what we basically found that after reviewing all AMD patients at Stanford over the last 12 years, which are like almost, who were also on atorvastatin, there were almost 1,400 patients. But similar to other studies, when we look at patients who used like very high dose of atorvastatin, 80 milligram daily, for long enough time to really have to be included in our study, they were at the end only like 21 patients, similar to other studies, because it's like a very high dose basically. But still, we found that although the drusen like resolved similar to previous studies, but still about 15 to 20%, about 20% of these patients actually progressed to wet AMD, and they had like a severe disease that needed injections into the eye. So basically, the two main conclusions here is that first, our study doesn't necessarily disprove previous studies that it doesn't work. It just maybe shows that it's really important to look at two things. For the people who are reading the studies, is what's the length of follow-up? Because all the previous studies where like the maximum follow-up was like 2.5 years, like 2.5 years. In our study, the average time to convert to wet AMD while on this very high dose was almost 42 months. And the range was up to 7 years. And we know it's really difficult in clinical trials to follow patients like for 3 years or 7 years. But it's important to consider this when we are reading studies about this chronic disease. The second thing for researchers and investigators is because in our study, we didn't find any clinical characteristics between patients who converted to AMD, to wet AMD versus those who did not. Except the stage of the disease of AMD, it was mostly intermediate in patients who converted to wet AMD versus it was mostly mild disease. But other than that, we didn't find any clinical difference in the clinical characteristics. So it indicates probably in the future, we have to investigate like genetic risk factors, the metabolomics of these patients to see what is the characteristic that really differentiating those who are benefiting from this atorvastatin 80 milligram daily versus those who don't. And that will be important in future studies.
Thank you for that. And you touched on it towards the end that definitely more research is needed in this area. Is there any sort of conclusions that you might be able to draw or that you could hypothesize about based on the results that you saw, the impact of statins on disease pathway, especially because it seems like the earlier you catch it or the milder it is, the more effective they appear to be.
Yeah, it could be. I mean, I think honestly, like it's maybe the first thing is we have like statins. We still don't know how exactly it's affecting or preventing this progression to wet AMD because it has multiple effects. It's although it lowers lipids, but we also know that it has a pleiotropic effect, such as inhibiting inflammation and affecting the endothelial cells and other functions, which we are still studying and understanding now. But I think it's important to be, maybe, as previous studies also suggested, to be careful in selecting these patients when we prescribe this, like, or we advise them that they may benefit from atorvastatin, this very high dose of the medication. And also the second thing, to be careful about making conclusions that it will be basically prevent the progression to AMD in general, because these studies, as I mentioned from our study and other studies, are limited by the small number of patients and the short follow-up period. We are the first to study this, like at least for this very high dose, that to follow patients for a long time, like up to 7 years, to see the benefit or the not benefit of that.
All right, and now before I let you go, was there anything else that you wanted to touch on from the study that you think is important clinicians take away from it when reading the data?
Yeah, I would like to mention like some of the limitations of our study. The first one is, of course, it's a retrospective study, so it's with all the limitations of retrospective studies, although like it was powerful in following patients for a very long time. The second thing, these patients were actually had like significant comorbidities, like they had like, these are high risk patients. That's why they were placed on like this high dose of atorvastatin by their cardiologist or by their neurologist, because they had these very high risk features. This doesn't mean that patients who are at least average patients will not benefit from the dose. That may be something we have to add to our conclusions, because we know that like systemic risk factors usually, and AMD, as we mentioned at the beginning, is a reflection sometimes of some high risk systemic risk factors, and we have to be careful about like these patients. Also, we didn't have the privilege of selecting like very specific group of AMD patients, which usually it's an heterogeneous disease. Some of them had high risk features similar to other studies, but some of them were not. So it's still like, it's not the perfect study to really make all the conclusions we need. It just like raise more questions and raise awareness when we read other studies and when we conduct more studies.